Welcome to Catholic Ethics and the Challenge of COVID-19, a live webcast series presented by the Catholic Health Association and Georgetown University, in cooperation with the Pellegrino Center for Clinical Bioethics. Thank you for joining us. My name is Jacob, and I will be the operator for today's presentation. Before we get started, I would like to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using your computer's volume settings. There will be a question and answer portion of the webinar. To submit a question, just click on the Q&A icon located on the bottom toolbar of the Zoom platform and enter your question. Please note that today's presentation is being recorded and both the recording and slides will be emailed to you. We are joined today by Nate Hibner, Director, Ethics for the Catholic Health Association. At this time, I would like to turn the presentation over to Nate for opening remarks. The floor is yours, Nate.
Thank you, Jacob. Good day, and thank you all for joining us for part 7 of the special series presented by the Catholic Health Association and Georgetown University, entitled Catholic Ethics and the Challenge of COVID-19. I would like to note that we have recently added 4 new sessions to this webinar series, which will begin on June 11th. Registration for these sessions opens soon on the CHA website, so be sure to visit and get signed up. Before I introduce today's moderator, let us take a moment to reflect on this prayer for peace and fortitude written by Elizabeth X. In this age of anxiety and stress, we ask for your presence to be made clearly amongst us. Be with us as we confront illnesses that leave many of us in a state of worry for our families, our friends, our colleagues, our communities, our nation, and our world. As hospitals and healthcare providers seek to continue the healing ministry of you, may they have fortitude for the road ahead, knowing that you are walking this journey with them with your mighty hand. Remind them of both their strength and your strength. We ask for your comfort upon those who have already lost loved ones during the time of viruses, and may healing be upon those who are physically suffering and spiritually suffering through this season. May the wilderness of this time and the uncertainty we may feel strengthen our resolve to lean on your word, abide in your presence, and be guided by your enduring and powerful spirit. You have been with us in every age and will remain a refuge, to take solace, to recollect our thoughts, to remember that all things of this world are fleeting, and this too shall pass. Let us recall the calming of the storm by your hand. Let us today and tomorrow and the days ahead lean on your fortitude and resolve to care for each other and support each other through this difficult journey before us in our lives, both collectively and individually. Amidst the darkness, the confusion, and the storm of worry, may your presence be made abundantly revealed so that your light, your hand, and your strength gives us steadiness, refuge, clarity of purpose, and hope. Amen. We are very honored to be joined today by 3 distinguished guests from Georgetown University who are focused on whether COVID-19 patients should be named publicly in order to alert potential contacts. Moderating our discussion is Dr. David Miller, who is the Associate Director for Academic Programs and Administrator for the Pellegrino Center for Clinical Bioethics at the Georgetown University Medical Center, where he directs the bioethics courses for first and second year medical students. I will now turn it over to David to introduce our conversation leaders.
Thank you very much, Nate, and thank you to CHA for hosting this series. I'm pleased to introduce Dr. Daniel Sulmasy, who is the Andre Helligers Professor of Biomedical Ethics and professor at the Departments of Medicine and Philosophy at Georgetown University. He's also the acting director of the Kennedy Institute of Ethics and a member of the Pellegrino Center for Clinical Bioethics. It's also my pleasure to introduce Dr. Robert Veatch, who is a professor of medical ethics emeritus and the former director of the Kennedy Institute of Ethics at Georgetown University. He remains at the Institute, where he currently serves as a senior research scholar. I will start off today's discussion by reading a case to which the presenters will be responding. After I read the case, Dan Sulmasy will offer his analysis, followed by Bob Veatch's analysis. Then Dan will offer his rebuttal, followed by Bob's rebuttal. After that, I will ask some questions submitted by the audience. And now the case. The COVID-19 pandemic hit while students from a large private university were on spring break. They received notification from the university's president that due to the pandemic, students who lived in dormitories on campus would be permitted to return to campus, but only briefly and at appointed times to retrieve their belongings. After moving out, students would no longer be permitted back on campus for the remainder of the semester. Classes would be held online. Some staff members remained on campus during this transition to facilitate the move out and clean and disinfect the campus buildings. On March 23rd, the faculty, students, and staff received an email from the university's Director of Public Health, who is a physician with a master's in public health. That letter read, "Dear community members, we have become aware that a university staff member has tested positive for the virus that causes COVID-19. The individual who was last on campus on March 16th is now well clinically. He is in isolation. They are in isolation at their permanent residence and are doing well. The university has already identified those members of our community who may have been in close contact with this individual, and we are working to notify them. Further, this individual's local health department has a protocol for identifying people who have been in direct contact with anyone testing positive for COVID-19, such as this university staff member. They will contact those persons so that they can self-quarantine and watch for COVID-19 symptoms for a period of 14 days from the last contact with the infected individual. Out of an abundance of caution, we are reaching out to you to make you aware of these developments." A professor in the philosophy department asked the ethicists in the medical school of the university whether such contact tracing suffices as a response to this discovery. The professor asked, "Don't the members of the community deserve to know who this is? Isn't there a mandate to identify this person in order to maximize public health benefits and slow the spread of this deadly virus?" And that is our case. Dan, would you please start us off with your analysis? Thank you.
Thanks, David. I'm sort of reminded of how fast things are moving in this pandemic by the fact this case comes from March 23rd, and most of us would think it almost obsolete at this point, something from the past. But given the fact that we're moving into a phase where we'll be identifying new cases as part of the opening up phase in order to protect the public, I think this is still relevant because it's a potential strategy that could be used. So I think it is necessary to ask whether we should be publicly naming, if you will, publicly outing persons who are COVID-19 positive, either as employees or in some other broader category, simply as citizens, as part of a containment strategy. My view is no. I certainly recognize that people have justifiable fears about COVID-19. It's a new virus, it's novel, it's not fully understood. It is quite contagious, and it is potentially lethal. But I think our responses to this, like any other public health problem, have to be measured. We can't abandon all of our ethical principles in order to pursue the common good of protecting people from the spread of this virus. Confidentiality is one of those other principles, and I think it's a significant one that we should not at all think about dismissing lightly. It's as old as Hippocrates. It's obviously not absolute. There are exceptions that we have recognized over the years. So if someone is suicidally depressed, or if there are direct threats to known individuals, or if they present a grave threat to the public health, we do have limits on their confidentiality and ways of going about using their identity in ways that can help protect others. I think COVID-19 certainly qualifies as a grave threat to public health, just like sexually transmitted diseases, et cetera. But there's also, it's important to recognize a principle of restraint in public health ethics. First of all, you have to make sure there are no good alternatives. Second, you've got to make sure that you're using the least invasive, least restrictive, least coercive means at your disposal to achieve the good that you're looking for. We could become, for instance, very draconian about this. Think of the strategies that were used in China. We could use surveillance cameras over the entire nation, figure out if anybody came within 6 feet of anyone else and they were infected, use their own GPS devices without their consent to identify them and quarantine people or get them identified and tested and treated. I've seen, and many of you probably did back a few months ago, pictures of grandmothers being dragged into paddy wagons by the police in Wuhan because they were violating curfew. That can control the virus, but I'm not sure that's the way we want to go. So the questions then are there alternatives to public naming of individuals? And I think the tried and true answer is yes. That's contact tracing. It has been proven effective. It's been used not simply for sexually transmitted diseases, but also for other respiratorily transmitted diseases like tuberculosis or meningococcus. If someone on this campus, for instance, a student had meningococcus, we wouldn't name them. We would do contact tracing for whoever they came in contact with. And this procedure of contact tracing can be ramped up, and people are planning to do that. Massachusetts is already employing thousands and thousands of people to do massive public health contact tracing. It's discreet, though. It's not public. You're not naming the person for everybody. You are looking to find a person who had contact, and you don't even typically name the person there. You say you have had contact with somebody who had the disease. It's imperfect, but I think it strikes the right balance, not sacrificing confidentiality at the altar of public health. I would also question whether public naming of individuals in a disease like this is going to add very much to our public health benefit. I really doubt it, because we will only make fearful lots of people who had casual contact for brief periods. That are very inefficient ways of transmitting the virus. Surface transmission is something that people fear by touching infected surfaces, but that's not a very effective way of transmitting the virus. It's probably not terribly dangerous. In large institutions, people probably don't even recognize the name, perhaps, of somebody, and so you also have to post the picture of the person. That would be like putting up a wanted poster in the post office. I think it would be very embarrassing for the person. And I think we have to consider the fact that it could be counterproductive. It could lead persons who are identified outside the institution, let's say by their own doctor, to not notify their institution of employment or other kind of institution, and therefore decrease opportunities for contact tracing, because they would fear being stigmatized. And so that would lead potentially to decreased public health benefit. At the most, you might want to announce that someone who tested positive for COVID was in the cafeteria on such and such a day at such and such a time. But that would be an alert. It wouldn't be even necessarily a cause to be tested, I would think. Since the time of Hippocrates, confidentiality has been recognized as one of the cornerstones of the doctor-patient relationship. It does have limits. The public health exception has long been recognized as one of those, but the way we typically go about that is by discrete contact tracing. If it's enough for tuberculosis, it should be enough for COVID-19, and I think we should avoid a kind of COVID-19 exceptionalism.
Okay, thank you, Dan. Bob?
Thank you, David. If a letter like this is sent out to the entire university campus, we really ought to ask why the letter is sent. It, I suppose, offers a little bit of benefit for people to be alert that there's at least a case of COVID-19 on the campus, but there may well be 20,000, 25,000 people who receive this notification. And the plausible assumption of anybody is they probably weren't in contact. I think the real purpose ought to be to alert people that they may be at risk. And in order to alert them, they need to know whether they reasonably were in the vicinity of this individual. Contact tracing goes part way, but only part way. For one thing, with contact tracing, confidentiality may by itself be jeopardized. At least the one doing the tracing knows the identity of the infected individual. If I'm at the Kennedy Institute and I learn by scuttlebutt that everybody at the Institute has been contacted and one among us has been absent for a couple of weeks, it's pretty obvious who the infected person is. So contact tracing jeopardizes confidentiality, but at the same time may miss lots of people. Suppose it's, say, the receptionist at the Kennedy Institute. That receptionist may be able to identify some of the people with whom he was in contact, but surely not everybody. Won't even know the names of everyone. So releasing the identity of the individual is a much more thorough way of alerting people so that they can determine whether they're at risk. Now, we might assess this with the notion that a core principle of medical ethics is confidentiality, but that turns out to be a much more complicated issue. Let's contrast both the Hippocratic ethic approach to confidentiality and a much more social ethic that's appropriate for Jewish and Christian medical ethics. In Hippocratic ethics, most people believe that there is a pledge of confidentiality. That turns out not to be quite true. What the Hippocratic Oath says is, I will not reveal, quote, that which ought not to be spread abroad. That begs the question, what ought to be spread abroad? The standard answer to that in Hippocratic medical ethics is you revert to the core idea of Hippocratic ethics that the physician works for the benefit of the patient according to the physician's ability and judgment. And what that has meant in modern Hippocratic ethics is that physicians have both the right and the duty to breach confidentiality when and only when they believe it's in the interest of the patient to do so. Now, the problem with that is sometimes a physician may believe it's in the interest of the patient to breach confidence where the patient doesn't agree. So in the 1970s, there was a substantial dispute over confidentiality, and both the American Medical Association and the British Medical Association abandoned the Hippocratic idea that the physician is the one who should determine whether it's in the interest of the patient to breach confidentiality. Right about that time, there were some dramatic cases that led to a new idea about when confidentiality should be breached. Let me mention them just briefly. In upstate New York, there was a man in the 1990s who somehow got exposed to HIV. He was convinced that one of his many female sexual partners caused him to become infected. And he irrationally became very angry at all women because of this. And he set out to intentionally expose as many women as possible to his HIV. Now, it turns out he confessed all of this to his physician. And the physician came to the conclusion that was later supported by New York health policy, that the physician has a duty to breach confidence, to warn people when they're exposed in a case like this. That meant that you breach confidentiality, not for the benefit of the patient, but for the benefit of others. About this same time, a graduate student at the University of California was having a romantic relationship with a woman, and the woman decided that she wanted to break this off. The male student, man named Podar, was so angry about this that he confessed to his psychotherapist that he was so angry with his girlfriend that he could kill her. And he said this in a way that was very believable, and in fact, he set out to kill her, and he did kill her. This led to an ethical and legal dispute over the question of whether there is a duty to breach confidentiality in a case like this, and it became law and became the ethical judgment of most people that there is not only a right but a duty to breach confidentiality when there is a grave threat of bodily harm to others. Now, let me contrast that with Jewish and Christian ethics, which supports a much more social view than the old Hippocratic view that you work only for the patient. There are many things in medical ethics that are social in nature. The ethic of doing research, for instance, for the producing of general knowledge would be impossible under the Hippocratic ethic of working only to benefit the patient. Organ transplant, the allocation of scarce resources, and most critically, the problem of justice for the physicianless poor are all excluded if you use the Hippocratic view, but not if you use a Catholic and more social view. My conclusion is that if there's a grave enough risk, then there's not only a right, but a duty to warn. And the infected person in the case we're describing should, first of all, want to disclose to serve the interests of his colleagues or her colleagues. But if the circumstances dictate and the risk is severe enough, then disclosure is morally required, and the school ought to identify who the subject is so that people can take appropriate precautions.
Thanks, Bob. Dan, we're back to you.
Yes, I get my 3-minute rebuttal with my good friend and colleague, Bob Veatch. Let me say a few things. First, that Catholic social ethics does in fact recognize rights as well as the common good, and recognizes rights to privacy and respect for confidentiality as part of the ethical and religious directives for Catholic health facilities. Second, to say that contact tracing is a lot older than the 1970s. It's been a cornerstone of public health ethics for many, many years, and particularly was used before there were even effective treatments such as penicillin. But third, I think the most important is that the case of Tatiana Tarasov that you're drawing upon does not simply say that any risk of bodily harm to grave bodily harm to others is sufficient to broach confidentiality. I think first, the differences between this case and those, both the Tarasov case and the HIV positive person, are that in both of those cases, there's either negligence or actual malice involved on the part of the person. Whereas I don't think the people who are walking around the campus with COVID are actually trying to infect people or trying to harm them. Second, the disclosure in those cases is to prevent future harm. The fact that somebody was on the campus on March 16th and you learn about it on March 23rd is not a future event that you're trying to prevent. It's not something the person is going to do in the future, like a murder or infecting somebody. Third, the victims are particular and they're already identifiable in those cases. And that's part of what makes the Tarasov precedent possible. And even in those cases, there's not public naming and shaming of the person. It is contact tracing of the individuals who are at risk. I believe in the Tarasov precedent, and I believe that it is reasonable under conditions that are similar to the Tarasov case to breach confidentiality. But I don't think the case of someone who is COVID positive walking around the campus meets those very stringent standards.
Thank you, Dan. We're going to go back to Bob for a response to that. Thank you.
Yes, Dan makes good points. It is true that in most Christian medical ethics, there is a notion of privacy and confidentiality, as well as a duty to one's fellow human beings. In this case, the importance of learning about the exposure, I think, is critical. Since we now know that COVID has a long period, or can have a long period of asymptomatic infection, it's really important for people to know, even if they were exposed before the infected one became symptomatic. Furthermore, if it's students that are being exposed, they have parents and grandparents who they will be living with for the next weeks, where the risk is even greater. One point that is sometimes raised, and Dan raised it, was the negligence that clearly was present in the case of the HIV patient and in the case involving the student named Podar who killed the young woman named Tarasov. Clearly those were guilt-ridden behaviors where we can assume that there was no negligence on the part of the infected staff member in the university. But intent is only taking us so far in a case like this. The real fact is that hundreds, maybe thousands of people had some degree of contact with this person, and they have a right to know and a duty to act on the information in order to protect others in their family. The timing of this is very critical. It's important that it was diagnosed and identified soon enough that the transmission may not have, hold on, I need to deal with a telephone ringing. The transmission may still be putting others at risk. Let me just stop there.
Okay, thank you both. I'm going to put the general discussion screen up. I think that we may have time for one question, and I have a few. I think that one question from the audience was, could you address the concern that harm might come to the infected person? We've seen that there have been some acts of violence against people who are either of certain races or who are suspected of being infected, and don't we have an obligation to protect the infected person?
I'll answer first. Yes, I certainly agree. At the very least, the person can be shamed and embarrassed by being publicly named. But yes, it's a good point that certain individuals have actually been at further risk than that, of being so stigmatized that acts of violence have been, or threats have been conducted against them.
Bob, did you want to say anything?
That's an important point and a factor that should be taken into account. In my view, becoming infected with COVID-19 is not a particularly stigmatizing event. It's not like having HIV, for example, where concerns about confidentiality are much more serious. I don't see why anyone ought not to be willing to publicly announce that they're infected so that others may take appropriate precautions. If there were a case where there was fear that some retaliation might take place, that would certainly be a factor that should feed into the calculation of disclosure of the name, just as the probability of others being exposed might be.
Let me take this as an opportunity for actually a different case that would be one in which we could have a point of agreement between Bob and myself, and that is that I think both of us would agree that it would be a good thing for someone, a noble thing for the person to voluntarily self-disclose for the benefit of others. And we have a terrific example here at Georgetown. It is not a violation of confidentiality because the person publicly self-disclosed, but the first case of COVID in Washington, D.C. was the rector of a local Episcopal church who got the word out to his parishioners because he was very much afraid that he might have transmitted the virus to communicants and to others who were in the congregation. So neither of us would disagree. I think that was a noble and good thing to do. Where we disagree is whether there is an obligation of the state to do that in a uniform way.
The only point of concern I would raise, I agree that it was a good thing for the Episcopal rector to announce publicly, but noble may be too strong a word. But my view is that there is generally a duty on the part of those who have been diagnosed and have exposed large numbers of people to make this information available. That is correlated with the fact that keeping the information confidential may be impossible in any case. I don't know how an Episcopal rector who ends up being hospitalized and away from his parish for quite some time could keep that information confidential if he wanted to. The theme of my remarks was, first of all, that it is a morally good thing to disclose one's identity, but beyond that, if the circumstances warrant, there is a duty to one's fellow human beings to protect them from the potential serious harms that are involved, permitting them to isolate or self-quarantine.
And my final brief counter would simply be that that duty is fulfilled if one cooperates with the contact tracing authorities and gives the names of all those persons with whom one came in contact.
I just don't get contact tracing. There would be so many people that one would either forget they've had contact with or wouldn't even know in the case of a university. I talk with people, students all day long in the university where I literally don't know their names. I stop by to chat or I run into them in the hallway or in a huge lecture class of several hundred people. You wouldn't be expected to know the identity even of people where you've had quite close face-to-face contact. So contact tracing probably breaches confidentiality and it still misses getting the critical information to lots of people who need it.
And let's not make the perfect the enemy of the good.
Well, thank you both. We have run out. Our time has run out. Thank you both. Thank you to CHA for sponsoring this series and for our audience for attending and asking questions. I'm sorry that we didn't get to all of the questions. There will be some, this series will resume on June 11th, and we hope that you will join us at that time.
And with that, on behalf of the Catholic Health Association and Georgetown University, I would like to thank you for participating in today's event. A recording will be sent in an email and will also be posted on CHA's website at chausa.org, where you can also find recordings of previous sessions in this series. Today's program is copyright 2020 by the Catholic Health Association with all rights reserved. This concludes today's program. Thank you and have a great day.